In this video, we're going to talk about healthcare costs, what drives healthcare costs, at least on a basic level, and then some basics about how healthcare costs have tried to be restrained in the past. So, without question, the US spends the most on healthcare in the world. So this charts the OECD countries, so essentially the high-income countries in the world, and how much they're spending on healthcare per capita. So essentially how much they're spending per person on healthcare from 2000 to 2016. In 2016, we were spending something like $9,500, $10,000 a person on healthcare. Other countries that are normally mentioned in the healthcare debate would be countries like Norway, which they do spend a lot of money, but it's not nearly as much as us. They're at the $6,500 level. We often talk about Canada and the UK. They have universal healthcare systems. Canada's just to the north. There's positives of it, there's negatives of it, but in providing universal healthcare, they're doing it at a much lower cost than we are, in that $4,000 to $5,000 range. And then Mexico to the south is spending only about $1,000 a person. But it's not just raw dollars. We also spend the most as a percent of GDP, or as a percent of our total economy, which is what GDP really is. So in this chart, it goes from 1980 to 2013. In 1980, we were spending about the same amount of our economy on healthcare as other European countries, other developed nations. We were at the top end of the range, but we are at least in the range. Since then, even though they have gone up a little bit, we have gone up a lot. So by 2013, we were spending 17% of our economy on healthcare alone. So 17 cents of every dollar that was spent in the economy was going to healthcare instead of going to somewhere else. And that over that 20-30 year time span, that started at about 8%. So more than doubled from 1980 to 2013. But despite us spending all of this money, we don't actually see the benefits of it. So our life expectancy, which is a pretty good measure, a pretty broad measure of how effective a healthcare system is kind of mediocre. We're in the bottom third of these developed nations. We're only at about 79 years. Mexico, who spends $1,000 per person, is at 74, 75. We're very close to them. Czech Republic, Chile, Turkey, Estonia, these aren't countries which typically hit the radar as being the most developed and take the best care of their population. On the other side, you have countries like Japan, Switzerland, Spain, where they have life expectancies well over 80 years old. So they're outliving us by 2, 3, 4, 5 years in some instances. And I really like this chart because they track per capita spending on the x-axis and life expectancy on the y-axis. And this is 2014. So in 2014, the US was spending about $9,500 per person. And if you draw a horizontal line from the y-axis, where the dot for the United States is, and look up, these are all countries who are spending less than us, but are living longer. They're spending less money than us on healthcare, but they are living longer lives. So why is healthcare so expensive? Why do healthcare costs seem to continually rise, and it seems like there's very little we can do about it? Well, first of all, let me just say that healthcare costs haven't gone up as fast in the recent history as it did in the past. So this paper by Moses III et al. Was published in 2015. They looked at 2000 to 2011. In the first time period, medical costs were increasing at about 8% per year. In the last time period, 2008 to 2011, it was about 4%. Now, these are both much faster than inflation. Inflation increases in the U.S. about 1 to 2% per year. So basically, our buying power decreases by 1 or 2%, or you need to earn 1 or 2% more a year to have the same amount of buying power as the previous year. But if medical inflation increases faster than inflation, and this could be double, it's often double the rate of inflation, that's going to increase both the overall amount of money we're spending on healthcare as well as the amount of GDP we spend on healthcare. If it matched the inflation, then we wouldn't have anything to worry about as long as it's constant. But the fact that it's growing faster than inflation, that's the worrisome thing. Now, in the early 2000s, the big driver was the use of of medical services. And this could be in part due to the introduction of Medicare Part D, the prescription drug benefit. So now that more people had access to it, they could use it more. But as time has gone on, even within this one decade, healthcare costs aren't increasing anymore because of more medical usage. Now, this doesn't include the Medicaid expansion from the ACA. This doesn't include the health insurance mandate. So it'd be interesting to see these numbers for this year. But at least from 2000 to 2011, really the primary driver in those later years of this study period was medical care itself. Was that physicians were charging more. Was that tests cost more. Screens cost more. Things like x-rays and MRIs, they cost more. Not that they were getting more of them, not that the population was growing, so we are simply offering more services, but that the tests themselves, the interventions themselves, were more expensive than they were in the past. Now, one other driver, and some people consider it a small driver, some people consider it a very large issue, is the idea of malpractice insurance. So malpractice occurs essentially when a doctor doesn't conform to standards. And I've given you the definition, it's the legal definition of medical malpractice. So it occurs when, first, a duty has to be owed. What this means is that a physician actually is treating a patient. So he accepts you as a patient into his care. If a physician doesn't do that, no, there's no duty and there's no malpractice. But once he does that, he has to conform to industry standards. So if a physician agrees to treat you, he has a duty to you to provide you with standard care. If he doesn't provide you with standard care, he doesn't reach that minimum threshold, you can say that his duty was breached. So he had a duty to treat you because he accepted you as a patient, but he didn't do it to the relevant standard of care depending on the practice and the specialty, so he breached that duty. Now, for malpractice to occur, it can't just be that a duty was breached. The patient actually has to be injured. So a duty is owed when a physician treats somebody. A duty is breached when that physician doesn't follow normal standards of care, and that breach needs to cause an injury to the patient. If no injury occurs, it's not actually malpractice. The next step is just, again, the deviation from that standard. So there was whatever he did or whatever she did as the physician just was contrary to the accepted standard. One of the easiest examples, or a classic example, is when a surgeon leaves a tool inside of a person, which happens, thankfully not often, but more than I would like to imagine. And then again, damage because of the injury, the patient suffered monetary or emotional damage. And that could be as simple as needing more health care. So they had to stay in the hospital longer. They needed to go back to the hospital. They had to go see a psychiatrist or a psychologist. So medical malpractice, the legal definition, is somewhat complex. It does take some practice to figure out exactly what all of these things are, but it is something that is seen as a driver of healthcare costs. And malpractice insurance, to protect the physician from having to pay everything out of pocket, is relatively expensive. Now, there's differences in insurance premiums depending on what specialty you're in. So I pulled a couple from Rhode Island. It was from 2014. If you are just kind of a general practitioner, family medicine, internal medicine, your malpractice insurance could be anywhere from $12,000 to $16,000, which is a lot of money. That's $1,000 a month or more just going to malpractice insurance. If you're a surgeon, though, it can go from $45,000 to $57,000. Which is probably more than most people's salaries who's working for you. That's certainly more than the certified nursing assistants, and it's probably more than some of the admins who are working for you making the schedules for you. If you're an OBGYN, your premiums for malpractice insurance alone, this isn't paying your salary, this isn't paying for where you're working and rent and things like that, this isn't for the tests and the equipment, just to protect you from malpractice, can cost you upwards of $115,000. $115,000. So for people in these specialty areas where you have a really high malpractice insurance premium, you do end up having to charge more for services just to cover these costs. Okay, so we spend the most We don't get a lot out of it. Malpractice is an issue, but what can we actually do to restrain costs? Well, some of the past efforts included things like HMOs, PPOs. An HMO, health maintenance organization, creates a provider network where your primary caregiver acts as a gatekeeper. You go to your primary care provider. If you need to see a specialist, he refers you to another provider, to a specialist provider within your network. And the HMO will only cover treatment within your network, within that network of physicians who've signed on as part of this program. If you go outside and see a physician not part of the network, you have to pay everything out of pocket. It will cover nothing. In a PPO, a preferred provider organization, you have an in-network physician network where you can get really good rates, you get really good services for seeing a physician within your network. But if you go out of the network, so a physician who hasn't contracted with your health insurance company, the insurance plan will still cover some of those costs and won't be completely out of pocket. So HMOs are cheaper than PPOs, but you don't have as much flexibility in terms of who you can actually see. You're really stuck within that plan. There are also health insurance plans known as catastrophic health coverage or catastrophic health insurance. These are very low premium plans, but they have very high deductibles. And a deductible is the amount of money you have to pay before the health insurance will kick in. So in a catastrophic health plan, maybe you're only paying $100 to $200 a month, but maybe you have a $10,000 deductible. And that means you have to pay out of your own pocket $10,000 before that health insurance plan will cover even a dime. So these can be very expensive if you get sick, and this actually can be a cause of bankruptcy in some instances. There is kind of a tax loophole where you can create a health savings account and you can deposit money into this account before you pay taxes on it, so it's kind of a pre-tax deduction. It lowers your tax burden, and basically you use this money to pay down your deductible. By using this plan, you're essentially making a bet on yourself that you're not going to get sick, because once you are going to, if you do get sick, you do have high out-of-pocket costs. There's also something else worth discussing in terms of restraining costs, and that's how things are being paid. So in the past, I've mentioned that it's mostly been fee-for-service. A doctor treats you, runs a scan, does a blood panel, does a physical examination, and he'll charge a rate for each one of those services. Medicare in particular is moving away from that fee-for-service type of system, and they're moving to a flat fee for what's known as a diagnosis-related group, or DRG. What these DRGs do is classify patients into different groups and subgroups. So very broadly, they'll categorize people in cardiovascular disease, and then they may specify between heart disease like heart attack, myocardial infarction, versus a cerebrovascular event or a stroke. And then what they'll do is they'll pay a flat fee based on that group classification. So they'll pay a flat fee for a heart attack. They'll pay a flat fee for lung cancer or for a preventive wellness visit. And then it's up to the doctor to provide care within that range. Many patients, they'll make money. They'll actually spend less money, less of their time, less resources than what they'll get paid. In other cases, they'll have to spend more because there are complications, there's hospital readmissions, there's more tests than you would have for the average patient. But ultimately, this flat fee is kind of the average of all of those cases. So that is another effort that has been done to restrain costs for healthcare in the United States.